Welcome back. We're going to spend a few minutes talking about the market for nurses. The one thing that I forgot to mention, or I guess kind of slipped my mind when we are talking about physicians, and it'll be the same when we get into the nursing side of it too. You have a lot of physicians, um, especially experienced physicians that are tired of the rat race of patient care that leave and take jobs, especially on the health plan side with healthcare consultants, with government agencies, um, and they're taking jobs as medical directors and making a very good salary. A very good salary, probably when we talk about economic rents, probably economic rents in excess of what they made when they were providing patient care. And trust me, the workload and the hours are a lot better and a lot kinder to these individuals that leave patient care and go into, and I'll call it administrative, that go into the administrative side of healthcare. And that's another aspect that's a drain on the supply of physicians is there are other alternatives out there. Once you get a medical degree, there are alternatives out there um, that don't necessarily involve patient care. So, as a physician, that's just something a lot of them are looking at, and a lot of them are heading in those directions because it's an easier way of life. They can spend more time with their families, and the the return on the investment they have in training is actually very good working as a medical director. But now we're going to spend just a few minutes talking about nursing degrees and the market for nursing. And basically, on the nursing side, there's 2-year degrees, 3-year degrees, 4 years degrees. There's MAs, masters. There's, you get a PhD on the nursing side. You've got nurse practitioners, and if you're a I think on the nurse, if you've got a PhD, you can prescribe medications. I know you can, as a nurse practitioner, prescribe medications. And in some states, you don't have to be, don't have any oversight from a physician. So what you're seeing is a lot of these physician groups or medical practices. They are trying to improve efficiency. They're trying to generate more output, and the way they're trying to generate more output, they're not really hiring more physicians. They're hiring physician assistants. They're hiring nurse practitioners. They're hiring health technicians, and they are expanding the support area. And in expanding the support area, they're able to see more patients per hour than they could previously. So, and most people refer to them as physician extenders because they are, in a sense, extending the reach of the physicians that are in the offices. So there's always physicians in the office that if they run into trouble or have something that they haven't seen before, they can touch base with the physician, and the physician will come in and maybe help the diagnosis and help with prescribing the medications. But they're doing a lot of the triage, and it turns physicians loose to almost kind of a consulting approach on physicians, and physicians like it. It's a great job opportunity for individuals that may not want to, especially on the nursing side, that may not want to be providing patient care in a hospital setting, but you can go into a physician's office and serve as a physician extender and see patients, and it's a lot less stressful than working in a hospital. At least I've been told from nurses that that's the case. So, and while we're talking about going to work in the hospital or working from a hospital to a physician's office, you have a lot of nurses that go from a hospital directly to a healthcare organization. So they're going to work for a health plan. when I worked at Blue Cross Blue Shield, I had several nurses that worked for me, and they were reviewing medical records, reviewing patients' charts, ensuring that the coding in the chart matched the episode of care. And they loved the job. It made they actually made more money than providing patient care. Plus, there was a lot less stress. Um, just it they love the job, and so that is definitely an alternative, and it's something that is definitely drawing away from the supply of nurses is the other alternatives other than seeing patient or the providing direct patient care. And what you so what you've got is healthcare production function impacts the demand for nursing degrees. And that is a true statement because that production function in a healthcare environment is going to determine the number of nurses. And it doesn't matter whether it's a hospital or a health plan or a government agency or a consulting group. That's going to drive the demand for nurses. And at some point, it's going to impact the supply of nurses. Now, fortunately, for nurses, you don't have hardly the lag time that you have for physicians because you can get, as I said, a 2, a 3, or 4 year degree. So, with an undergraduate degree in nursing, and you can do very well in the healthcare environment as a nurse. So, it's only if you want to go on and get a master's or a PhD or become a nurse practitioner, there's going to be some additional training there. But it's not going to be nearly the lag that you see in the physicians trying to go to medical school and then a residency and an internship. Hospitals, I'm sure you're probably not too surprised at this. Hospitals are the main employer for nurses. Intensity, depending on the intensity of the hospital, it's going to impact the nurse to patient ratio. You see, again, as I talked about, some nurses shift to an ambulatory setting. Maybe they go to work for managed care organizations. Maybe they're, go into business on their own as a nurse practitioner. They go to a physician's office. They're going to, and the authors talk about per diem nursing, and that has become a very lucrative aspect of the nursing profession is working on a per diem. You can float around. You may, especially if you're single, these nurse staffing organizations will move you from, city to city. Pay for your expenses while you're there, and pay you a very lucrative salary to be a per diem nurse. And you can set your own hours. You can set the number of days you want to work. You can set the time of year you want to work, and you can almost pick the cities you'd like to, try living in while you're a nurse. So per diem nursing, it's a great opportunity for the nursing profession. You've also got integrated health systems that are driving this supply and demand characteristic. So you've got a lot of alternative avenues for a nurse to generate income once you get out of nursing school, because now in this day and age, you don't have to go to work and work the rest of your career in a hospital. You've got a lot of opportunities as a nurse. And nursing, versus other professional opportunities in the healthcare field, you've got, to me, nursing field probably opens a lot of doors with a degree in nursing. Public policy uses nursing vacancy rates to mitigate shortages. And again, because it's a shorter lag time, so public policy does a better job with the vacancy rates because, as I said, you can get out with, and a lot of institutions like a 4-year degree in nursing. So you can spend 4 years in a nursing school and get out and you're ready to go. And it's not like you've got a 4-year degree in medical school and internship or the rest. You don't have that really long tail or the really long lag time from the time you identify a shortage until the time you've got capable individuals ready to go to work in the workforce. Wage rates, level of direct patient care impact nursing shortages. And individuals will always continue to go to nursing school as long as the marginal revenue is greater than the marginal cost. Again, it's the marginal decision rule that you spent, I don't know how much of your time taking you know microeconomic classes, and we've talked about it in this class too. It's that marginal decision rule, one of the three pillars of economic thought. And the supply and demand responses are quicker than for physicians. And again, it's that lag time from the time you decide you want to go to nursing school until you get out with a degree in nursing and can go to work and join the workforce. Nurses are part of two-earner families, and vacancy rates are typically lower during recessions or economic downturns. And that makes sense. So part of a two-earner family, and during when the economy's booming and things are growing great, the individuals may step back from being a nurse. They may take some time off, spend some time with their family, homeschool their kids. There's a lot of things a lot of flexibility it gives you. And then if you see a recession or a downturn, or just like now, you may have a lot of individuals that maybe had taken some time off during COVID and they didn't want to, be, involved in patient care. And now we're in, high inflation rates and, uncertain future. Maybe they've all of a sudden decided, hey, I'm going back and going to, restart my degree as a nurse. And I think it's this two-earner families on the nursing side of the house where you're really seeing this bump up in the per diem nursing industry. So again, per diem nursing, a lot of individuals really like it, especially a lot of single individuals really enjoy the per diem nursing. Cyclical supply and demand for nurses is driven by public policy and economic indicators. Again, public policy, how much are they subsidizing? What incentives are they providing for individuals to go to nursing school? And then we had talked earlier about the economic indicators. If it looks like inflation is going to stay high, if it looks like we're going to head toward a recession, things go a little bumpy financially, you're going to see a lot more nurses get back into the nursing profession. CMS unions, cost containment policies at managed care organization impact wages. And that's true. It depends on and a lot of nurses are unionized. It depends on how strong a union the nurses have in a particular area. It depends on the demand for nurses on a managed care organization. Depends on what CMS is looking for from a nursing perspective. I don't know whether they ever actually went on strike, but a couple of weeks ago, Kaiser, not only nurses, but a lot of the employees at Kaiser were going to get ready to go on strike for higher wages. Kaiser probably going to have to up the pay for them. So it's not unusual for nurses to be part of a union and go on strike. In Buffalo, they went on strike. I was there 12, 13 years, and they went on strike more than once in the time I was there. And things got really dicey with the hospitals in town. It was push and shove, and you didn't know who was going to win. But ultimately, the nurses won out. They got what they wanted. You're talking about, and then the fourth bullet down, talking about monopolistic or oligopolistic buyer of nursing services. There's collusion in wage setting. Increase in wages of new nurses and impact of wages on current nursing. And that's where in a tight community like Buffalo was, you had two huge hospital systems. You had Kaleida and you had Mercy. And there was, could have been some, I hate to say collusion because I don't know that there was collusion, but there seemed to be some cooperative effort to kind of dampen the wages on the nurses. So nurses ended up going on strike, and they always have an issue. And it's not just nursing, it's pretty much any industry that you work in. New employees tend to demand a higher wage rate than sometimes current employees. Somebody's been there for maybe 10 or 12 years and been plugging along with, COLA, cost of living, um, adjustments of, 2%, 3%, tied to the consumer price index. And all of a sudden, you have a shortage on nurses, and it's not typically the experienced nurses that have been there that get the big boost in salary. It's these newbies coming in to get the big boost in salary. And things get a little testy, and especially in the nursing profession when that happens. The marginal factor cost is less than the marginal factor of revenue. Then you're looking at a profit maximizing when you hit marginal return equal to marginal cost, and that's what's going to drive a lot of nurses deciding whether to either stay in the nursing profession, whether to continue direct patient care, whether to go to work for a health plan, whether to go to work for a government agency, maybe they go to work again for a consulting group that sends them around the country, teaching health plans or teaching providers' offices how to be more efficient, how to use their nurses more efficiently. Per diem temp agencies mitigate shortages. That's what they're there for. They get those nurses in a per diem and temp agency. They get higher salaries, fewer benefits, flexible schedules, and a lot of nurses in these temp agencies, if their spouse has health benefits or healthcare benefits, they don't, they could care less whether they give healthcare benefits to the temp agency because they've got it, the healthcare benefits through their spouse, or at least through their spouse or partner, and no impact to the current wage rate. So there's no impact to the wage rate of the nurses that are entranced or ensconced in a particular hospital in a particular area if you're supplementing the workforce with these per diem and higher salary nursing, because it's not going to impact who's already there. You're just using them to fill the gaps and to fill the shortages. Going to kind of wrap this up between the nurses and the physicians. And remember, there are a lot of individuals in the healthcare marketplace other than just physicians and nurses. DeWars just kind of concentrates on these two, and I typically concentrate on these two also because there's enough specificity here between these two groups of workforce in the healthcare marketplace. So, and the training is specific. And then I go back to my medical economics team that reported to me, and when I worked in Buffalo, a lot of those analysts didn't have a healthcare background. They had a degree in statistics, they had a degree in applied mathematics, it may have been economics or finance. And those types of degrees, you can work just about in any market economy or just about in any industry because it's a skill set that's required in a lot of industries. If you've got a degree in nursing or a physician, you're pretty much, I don't want to say hung in the healthcare arena, but that's why I think the author and the text, concentrated on these two groups. And then kind of summarize the physician market with barriers to entry and higher rates of return. Again, public policy and the AMA creates these barriers to entry through slots in medical schools, teaching research facilities, the cost and the psychological impact. So it's a time and cost barrier to entry. Managed care organizations, CMS, impact physician rates of return, specialty distributions, and geographical distributions. And that is a very valid comment because it is driving. It's these managed care organizations and CMS through Medicare and Medicaid. They are driving a lot of the rates of return, and especially the specialty distributions. Increase in female physicians, primary care physicians. And I keep asking, why are there access issues? Why can't, if I get sick tonight and I need to see a physician tomorrow, the chance of me getting in to see my primary care physician tomorrow is just two, slim and none. Um, Sometimes it takes 2 or 3 days for me to get in the scene. So why are we having access issues? Monopolistic power appears to impact nursing wages, alternative supply of nurses and wage scale. So monopolistic, I guess the market power of a hospital is extremely significant, especially in a small community. So you can, a hospital in a small community, and if there are no other options, if you're a nurse and you want to work, and you want to stay in that community, you're going to have to be almost in a situation that you're a price taker, a wage taker, because the hospital holds a lot of market power. So if you want to be a nurse, maybe you want to make sure that you're in a community that have multiple hospitals. Best case scenario is multiple hospitals, multiple physician offices, multiple managed care organizations, because at that point you can shop around and drive your own price. Unionization of minimum wage scales may mitigate nursing shortages, and that's true. If you've got minimum wage scales, so if you're setting that price floor on the wage rate, and that price floor is set at a high enough level, you have individuals thinking about going to nursing school. They see that and they think, well, it's at this level today, and within 4 years, maybe it's to this level. I think I'm going to go and get my degree in nursing because there are a lot of opportunities with a degree in nursing. And with that, I'm going to wrap up the healthcare workforce market. I think the next time we get together, seems like we're going to talk about technology. But until then, enjoy your evening. Thanks for joining.